Good evening, plastic surgery aspirants. We are here for the INISS NEET recall of plastic surgery questions, and I'm your plastic surgery faculty, Dr. Vijay. I'm a professor of plastic surgery working in PIMS Medical College. Here we shall revise few questions which were asked in the previous INISS NEET and is also tough. I'm not going to touch any controversial topics as you're nearing the exam. Be confident. Again and again, revise the standard questions like flaps, grafts, congenital anomalies of the hand, cleft lip and palate, facial nerve palsy, brachial plexus, and the cosmetic chapters like blepharoplasty, fat grafting, liposuction. So all these are important chapters, and burns and compartment syndrome. So these are all the very important topics. Okay, here let us see a few of the important questions. For elbow animation, all can be used except this particular question. If they ask about reanimating any upper appendage, it means it's a brachial plexus question. Latissimus dorsi and pectoralis major are used as a pedicled muscles for elbow reanimation. Gracilis can be used as a free flap, but trapezius cannot be used because it won't reach the elbow. But trapezius is used as a tendon transfer technique for the shoulder. So if it is for the elbow, it is not trapezius. But if it's for the shoulder, trapezius can be used for tendon transfer, both for shoulder abduction and external rotation. So the answer is trapezius. In brachial plexus injury, for nerve transfer of elbow joint, the nerve to the FCU is transferred to the brachialis and biceps brachii for which movement? It is a very obvious question. Biceps brachii causes elbow flexion and not extension. So the answer is flexion of the elbow. So let me talk about the surgical management of brachial plexus. Surgical management of brachial plexus is mainly proximal exploration, visualization of the cut injury, and identification and repair. Or if the time is very late and we have missed the time of primary repair, it is distal nerve transfers. If we have missed the time of 12 to 18 months wherein the motor in plate potentials must have atrophied, then no other option other than to go for tendon transfers. So nerve exploration in the neck is possible only for the very limited initial period. Now transfers are possible for next set of period. If more than 12 to 18 months, only tendon transfers are possible. Among various factors, the time is the most important factor. Of course, other factors like where is the zone of injury, what is the nature of injury, like whether it's a root avulsion or just a rupture, available of other donor nerves, available of other musculotendinous units, presence of the vascular injury, and also the surgeon's comfort with the technique. Not everyone is able to do a free functional muscle transfer. So that also decides what treatment to be done for brachial plexus. So let us see proximal exploration. Proximal exploration can be done within the first 3 to 5 months of a brachial plexus injury. What do we do here? Here we open the neck, we identify where there is nerve rupture. If there is a nerve rupture, we do a primary repair or we repair the nerves by cable grafting. If there is a root avulsion or a spinal nerve rupture with proximal stumps very small to co-opt, then we can use either an intraplexal transfer or an extraplexal nerve transfer. Intraplexal transfer uses sometimes the same proximal steps which has to be tested by somatosensory nerve studies, that whether it's intact or not, and it can itself be used to the distal cuttings, or extraplexal nerves like spinal nerve, intercostal nerve, phrenic or cervical motor branches C3 and C4. Nerve transfers. Okay, so if either we have missed the primary nerve repair or a primary nerve repair has been done and results are not there, we do a nerve transfers, distal nerve transfers. Usually it is done by 3 to 9 months. The main advantage is all the nerve transfers are done away from the brachial plexus injury area and therefore no need to go through the fibrotic scar. Disadvantages, of course, the muscle from which we are taking the donor nerve goes for an atrophy. So we have to find an expendable muscle. And after transfer, the patient has to cortically readapt for post-motor reinnervation and re-education. So this is a huge tabular column which shows what motor nerves are expendable to do what transfers, out of which the most commonly done motor nerve transfers are for axillary nerve, a triceps transfer is done. So here you can see, okay, for so So for an axillary nerve, you can do a triceps transfer. For a musculocutaneous nerve, we usually transfer the median and the ulnar nerves. Ulnar nerve and median nerve transfer to the musculocutaneous nerve is also called as a Oberlin transfer. In dedicated plastic surgery units, the commonly done nerve transfers are the overlap transfer and the axillary transfer and the triceps nerve transfer to the axillary. Other transfers are all mentioned. It is all given in the Grab's 8th edition. But most important are the median nerve and the ulnar nerve branches are transferred to the musculocutaneous for elbow flexion, and the triceps nerve branch is transferred to the axillary nerves or the shoulder abduction. So this is a tabular calling giving the sensory nerve transfers the various options possible. Of course, the median and the ulnar nerve form the main palmar sensations. These various options can be used for the sensory nerve transfers. If exploring and repairing is over, or if nerve transfers are not working, then the only option left is a tendon transfer. It can be a pedicled tendon transfer or a free functional muscle transfer. So usually it is done for a late presentation of more than 9 months. Okay, tendon transfer, okay, is only a lifeboat. It is not the first option. And the tendon transfers are usually paired with other procedures like the shoulder or the wrist arthrodesis. Free functional muscle transfer, Gracili's free functional muscle transfer is the most popular free functional muscle transfer for the elbow flexion, but the same can be used for wrist extension and finger flexion also as a double FFMT transfer, either as a single transfer or as a staged transfer. So this is a tabular column giving the various options for tendon transfer. Again, like I previously told, latissimus dorsi and pectoralis major can be transferred to the elbow flexion as a pedicle transfer. Free functional muscle transfer can be done for elbow flexion, and stainless flexoplasty, wherein the common origin of the flexor contracted muscles can be released for elbow flexion. Among the other transfers, trapezius transfer for shoulder abduction is the other commonest transfer. So in tendon transfers, pedicle transfers, trapezius transfer for shoulder abduction, LD and pectoralis major as a pedicle transfer for elbow flexion, and free functional muscle transfer for elbow flexion are the commonest tendon transfers known. The various complications are for exploration, lymphatic leak, vessel injury, and pneumothorax. For distal nerve transfers, especially if you are doing intercostal nerve transfer, the intercostal nerves are running on the lower border of the inner surface of the rib. So while harvesting, you might damage the lung and cause pneumothorax. And during tendon transfer, improper tendon lengthening and improper balancing techniques and can lead to joint contractures, tendon bowstringing, and as it is a free flap, the well-known complication of pedicle thrombosis and loss of flap is always there. Median nerve injury, what is the sign seen? You well know Fromen's, Penn's, and Cart's test is ulnar nerve injury. Ape thumb deformity is mainly for the median nerve injury. The next few slides are on median nerve injury because that is the commonly asked nerve. Of the tendon transfers by EAP was you shown for achieving which thumb function? This particular question in the previous meet was asked by giving a picture in which the extensor indicis proprius was taken and wrapped around the distal forearm, and they were asking what is this transfer. So that was an EAP transfer for opposition. Let us see the median nerve. Median nerve comes from C5 to T1. Okay, it enters the forearm between two heads of the pronator teres, and there it innervates that the pronator teres. The superficial is FDS, the FCR, and the palmar is longus. Before giving the anterior interosseous nerve, the anterior interosseous nerve, which is a branch of 6 to 8 centimeters distal to the here you can see the anterior interosseous nerve distal to the elbow. It mainly supplies the deeper muscles, flexor pollicis longus, flexor digitorum profundus, and the pronator quadratus. After which, the median nerve continues distally and gives a palmar cutaneous nerve branch, which supplies the palmar triangle. and the median nerve provides sensation to the radial 3.5 fingers. As a motor branch from the carpal tunnel, there is a recurrent branch which is the main motor nerve to the thenar muscles. And the thenar muscles, as we all know, is the abductor pollicis brevis, superciliary abductor flexor pollicis brevis, and opponens pollicis. And of course, the motor innervation of the index and the long finger or the middle finger lumbricals is there by the median nerve. So, in a high median nerve palsy, there is, since the pronator is gone, there is loss of pronation. Index and the long finger flexion is lost. IP joint flexion because the FPL is lost and thumb opposition is also lost. So the functions to be restored are mainly the thumb opposition and the thumb flexion, like FPL function. Index and long finger, DAP and PAP joints to be flexed only in high palsy. So here you can see the median claw, and this is the Pope's blessing sign or the Benedict sign. Okay, here if there is a lesion above the AI, above the anterior interosseous nerve, you get this Pope's Benedict sign. In a distal median nerve lesions below AI, you can get a median claw hand. So, the tendon transfers for median nerve palsy primarily targets the abductor pollicis brevis because that is the most important muscle in thumb opposition. Whenever you talk about a tendon transfer, three important things are there. What is the donor muscle? What is the insertion site? And what is the route or the vector it is better used? So, the best vectors for an opposition transfer are the vector should be parallel to the ABP line. The vector should start from the pisiform to the base of the proximal phalanx to give the best opposition moment. Sometimes pulleys are used to achieve this best vector. The pulleys may be FCU loop, palmar aponeurosis, transverse carpal ligament, or FCU tendon itself. These are all the best loops used. The four commonly used abonanzoplasty procedures are Kamitz procedure, which uses palmaris longus, FDS ring opponentsplasty, EAP opponentsplasty, and the abductor digiti minimi opponentsplasty. It is also called as the Huber's transfer. First, the Kamitz transfer. Here, the palmaris longus tendon is used with an extension of palmaris aponeurosis, which is indicated in severe carpal tunnel syndrome, advanced thenar atrophy. The advantages are ease of harvest, lies in the same surgical field as carpal tunnel. It lacks a functional deficit. The disadvantages are the tendon may be damaged in a traumatic median nerve and therefore it cannot be used. It is a weak vessel and doesn't have the ideal vector. So, Kamitz transfer does not have an ideal vector to produce true opposition. FDS opponentsplasty here, FDS tendon, especially to the fourth finger or the ring finger, is harvested distally, retrieved to the carpal tunnel, and rerouted to the abductor pollicis brevis insertion. It is passed through the sheath of the FPL. Then it is called as a Royals FDS opponentsplasty. If it is rerouted by creating a pulley in a strip of FCU, it is called as Bunnell's FDS opponentsplasty. If the tunnel of the tendon is done subcutaneously to reach the tendon, the thumb, it is called as Thompson's FDS opponentsplasty. The main disadvantage is it is used only if the median nerve injury occurs distal to the insertion of the FDS. If the FDS itself is injured, then of course we cannot use this muscle. The last is the Huber's transfer, in which the abductor digiti minimi is transferred subcutaneously to the adductor tubercle or the ABP tendon. The transfer is synergistic to opposition and provides a good strength and excursion, but there is a limited availability to the palmar abduction. It is usually indicated in children with hypoplastic thumb deformity. So Huber's transfer is an opponentsplasty common in children with hypoplastic thumb deformity. EAP opponentsplasty is mainly used in high or low median ulnar nerve palsy. It is mainly, here we are using a motor which is innervated by the radial nerve. It is rooted around the ulnar aspect and it is sufficient to produce the thumb in opposition. The various advantages are, here you can see it is rerouted around the distal forearm and it comes here, the abductor pollicis brevis. The various advantages are ease of harvest, availability both in high and low ulnar palsies, and minimal functional deficit. EAP is usually present ulnar to the EDC slip of the index finger. It is divided, wrap around the distal forearm, and it is brought to the abductor pollicis brevis tendon. This picture was given in the previous exam, and the answer is EAP opponentsplasty. Patient with history of pain while working increases on flexion, numbness, tingling in the thumb and the index finger. So if the thumb and the index finger is involved, usually it is a carpal tunnel syndrome. But whether it's a pronator teres syndrome or not depends on whether the palmar aspect sensation is present or not. So if there is a sensory loss in the palm, then it is a pronator teres syndrome or the median of compression is quite proximal. If there is a sparing of the sensory loss in the palm, then it is a carpal tunnel syndrome with a median of compression only in the carpal tunnel. As the palmar branch of the palmar cutaneous nerve branch of the median nerve originates 3 to 5 centimeters proximal to the carpal tunnel and goes over the roof of the carpal tunnel, it is not compressed in carpal tunnel syndrome. This is a simple anatomical concept with which we can diagnose a pronator teres to the carpal tunnel syndrome. Diagnosis of these median nerve compressions is mainly historical and physical examination. Aching pain in the tunnel area, numbing and tingling sensation in the radial digits, thenar atrophy, and provocative maneuvers like Fallon's test, Tinel's signs, Durkin's test, wherein it is pressed over the carpal tunnel, and scratch collapse test, which tests the sensory innervation of the index finger mainly, are the various provocative maneuvers. Of course, we have the electrodiagnostic tests, and radiograph for the wrists are indicated for evaluation of the wrist pain, because sometimes a ganglion in the wrist or a neuroma in the median nerve, which is present in the carpal tunnel, might also be the reasons for the CTS, and therefore sometimes CT MRI needs to be done. Initial treatment of the carpal tunnel syndrome is with wrist splint. Ask the patient not to do much of the wrist excursion. The wrist is held in a position of decreased tunnel pressure. Hand exercises will always aggravate the CTS. Give anti-inflammatory medications, steroid injections if required. Sometimes diuretics and oral steroids, which are prescribed outside, are actually not indicated. Vitamin B6 is given if there is a neuropathy. If all these symptoms keep on progressing in spite of the conservative management, we have to release the transverse carpal ligament and the distal antebrachial fascia of the forearm via palmar incision. Internal neurolysis is not routinely indicated. But if intraoperatively you find any ischemic nerve, or if you find a lesion compressing the nerve, you need to excise the lesion or do a neurolysis. The same median nerve can get entrapped between the two heads of the pronator teres, in which it is called as pronator teres syndrome. There is compression of the median nerve at the elbow, which causes pain in the hand and the distal wrist. There is no spontaneous pain in the region of the pronator. It is exacerbated only by the pronator forearm pronation. The early symptoms are there is weakness of pinch, dropping things when the wrist is held in flexion, intermittent aching pain in the wrist. Hand weakness involves FPL and FDP, profundus of the index finger, and the pronator quadratus muscle. Numbness is the late symptom and typically occurs at the right. So the thenar muscles maintain the normal strength with the PMME, and the symptoms of the hand numbness are usually provoked by firm palpation of the median nerve, just proximal and distal to the elbow crease, and with pronation against resistance. Numbness occurs in less than 60 seconds and is considered abnormal. To assess the strength of the muscles generated by the anterior interosseous nerve, the wrist is at neutral position. MCP, PAP, and the DEP joints are flexed to 80 degrees, and the patient cannot do a O sign. The FPL is tested with the wrist in neutral and the thumb in metacarpal abduction. PMNE is usually confused with the carpal tunnel syndrome. The thenar area tends to be involved distinctly different from CTS. The palmar cutaneous nerve is a branch of the median nerve, provides the cutaneous innervation in the thenar area. It does not undergo compression in the carpal tunnel and hence spared in the carpal tunnel syndrome. Non-operative therapy here also, like ergonomic modifications, like avoiding the forearm pronation by using split keyboards, a vertical computer mice, voice-activated speakers, and driving with the hands on the bottom half of the steering wheels can be used. But if they are not getting cured, then a surgical decompression is the best method. All areas of possible compression of median nerve around the elbow should be released. Deep fascia, Sudhas ligament, which is the ligament from the spur from the humerus to the medial epicondyle. Deep fascia of the proximal pronator teres muscle, bicipital aponeurosis, deep fascia of the ulnar origin of the pronator teres, and the deep fascia of the humeral origin of the pronator teres, and fascia of the arch of the FDS. All should be removed, and they are all shown in this figure. Digital arteries are formed by which vessel? Digital arteries are usually formed by the superficial palmar arch. which is actually found to be the ulnar artery and the radial artery. Brachial artery, which is the main supply for the forearm, divides into radial and the ulnar arteries in the antecubital fossa. The radial artery mainly runs towards the wrist, radial to the FCR, and the larger dorsal branch passes through the snuff box to the deep arch in the palm. So the main contributor of the deep arch in the palm is the radial artery. Small volar branches continue to the superficial arch. Ulnar artery runs between the FDS and the FDP muscle. It is palpable radial to the flexor carpi ulnaris, and it is radial to the ulnar nerve through the Guyon's canal. Larger volar branches contribute to the superficial arch. Therefore, ulnar artery is the main contributor of the superficial palmar arch, whereas the small vessels from the ulnar artery contribute to the deep arch. Vascular to the corpus is by the both the anterior interosseous and the posterior interosseous, ulnar and the radial arteries. The common distal arteries usually arise. You can see the common distal arteries here. They usually arise from the superficial palmar arch, which is mainly contributed by the ulnar artery. Princeps pollicis artery is a main artery from the radial artery portion of the deep arch. Okay, from the radial artery portion of the deep arch, and it supplies the thumb. Which of the following is not found in the proximal row carpal bones? The answer is trapezium, which is found in the distal row. Of course, pisiform, triquetrum, lunate, and scaphoid, followed by trapezium, trapezoid, capitate, hamate. This is the proximal to the distal row. The pulley to be released for trigger finger is which pulley? A1, A2, C1, C2. It is A1 pulley. Congenital trigger finger is a condition which is common at least in 3.3 of the 1000 live births in the first year of life. In congenital trigger finger, the thumb is always found in a flexed position. You can't see a real trigger finger as in adults. The patient usually presents with a fixed flexion contracture of the IP joint of the thumb 25 to 35 degrees usually. Mainly, the patient will not complain anything because the patient is a child. The patient's father or the mother will tell that their child's thumb is, we are unable to extend the thumb either both actively or passively. Sometimes the age of presentation can be as early as 8th month when the pincer grasp is developing. Sometimes there is a presentation only up to 2 years. Here, there is a no-task node, which is nothing but a palpable thickening in the flexor pollicis longus tendon, which is usually present just at the proximal to the A1 pulley. The nodule obstructs the tendon glide, and therefore a trigger thumb is there in the congenital phase. But like I said, in congenital trigger thumb, the triggering is not usually present, only a fixed flexion deformity is present. Initial treatment for congenital trigger thumb are a period of observation can be left, but 75% had improvement without residual deformity, and splinting is no benefit much. Surgery is release of the A1 pulley with an incision, transverse incision over the proximal flexion crease. The only problem is very high chance of injuring the radial sensory nerve to the thumb. Therefore, we have to avoid the neurovascular bundles. This is the site of release of the A1 pulley. A1 pulley is such a large pulley. You have to put a transverse crease till the dermis, preserve the radial sensory digital nerve, then release the sheath. Contraindication of surgery in the radial club hand is when there is no functional deformity. What is a radial club hand? Radial club hand or a radial longitudinal deficiency is a congenital failure of formation of radial column. It can be a mild hypoplasia to complete absence of the radial side bones, especially the radius, carpal bones, and even the radial digits. The radial musculotendinous units such as the FPL, the brachioradialis, the flexor carpi radialis may be absent or hypoplastic, or sometimes they form a cord-like structure which tethers the ridge, and thereby the wrist is in an angulated position in the radially. 1 in 5,400 live births, you can find this condition. It is due to damage of the apical ectodermal ridge during the 4th to the 7th week of intrauterine growth development. Usually, the radial club hand is associated with Holt-Oram syndrome, Fanconi syndrome, thrombocytopenia absent radius syndrome, and Bacterial anomaly. It is associated with medical or musculoskeletal anomalies such as congenital heart malformation, blood dyscrasias, and renal or gastrointestinal dysfunction. Bain and Klug classification is usually used to assess the radial club hand. Type 1 is a short radius, type 2 is a hypoplastic radius, type 3 is partial absence, and type 4 is complete absence. This Bain and Klug classification is modified by James to indicate thumb hypoplasia also. It has been found that the main prognostic factor in a radial club hand is presence or absence of thumb. So modified by James to include three main factors, out of which main is thumb hypoplasia. The other two factors are radioulnar synostosis and carpal anomalies. Treatment for the radial club hand involves passive stretching and serial splinting initially. Sometimes distraction osteogenesis with an external fixated device can be used for at least 6 to 8 weeks even before surgical correction or as a prime treatment. Surgical treatment complains of various principles. 1. Straightening of the bowed forearm, correction of the radial and the volar subluxation of the carpal bones, improvement of the limb length to optimize function, improvement of aesthetic appearance, and treatment of thumb hypoplasia. Centralizing the carpal bone over the ulna involves rebalancing the musculotendinous structures, which results in angulation and limb shortening, and therefore surgery is usually contraindicated if the patient is having a no functional deformity. If the patient is able to feed him, able to do his day-to-day activities, and bothered only about cosmesis, sometimes we might damage whatever the patient is having, and it might be a cosmetic excellence, whereas a functional disaster, and therefore it is not advised to be done. Block classification is used for which condition? Block classification is mainly used for thumb hypoplasia. Thumb hypoplasia is a condition in which the size of the thumb can be small or sometimes it can be absent. And the muscles associated to the thumb, the thenar musculature can be hypoplastic. The web space associated with the thumb, the first web space contracture can be present. And the joint associated with the thumb, carpometacarpal joint, stability is affected. In type 1 classification, there is only a minor thumb hypoplasia. In type 2, the web space is narrowed. There is a hypoplastic thenar intrinsic muscles and MCP joint instability. In type 3, again there is web space narrowing. Thenar intrinsic muscles are absent or hypoplastic, MCP joint instability, and extrinsic tendon abnormalities and skeletal abnormalities. Type 3A is extrinsic skeletal hypoplastic metacarpal with a stable CMC joint. Type 3B is partial metacarpal aplasia but unstable CMC joint. Whereas type 4 and 5 are, type 4 is a floating thumb and type 5 is an absent thumb. The surgical treatment of thumb hypoplasia mainly depends on the presence of a stable CMC joint. So the one factor which decides the treatment of thumb hypoplasia is CMC joint. In block type 2 and type 3A, wherein there is widening of the first web space, an openangioplasty procedure and MCP joint stabilization is done. Whereas in block type 3B, 4 and 5, the thumb is ablated and the reconstruction is done with an index finger polycization, transferring the index finger to thumb position. So treatment of 3B, 4 and 5 is polycization. Treatment of type 2 and 3A is widening of the web space, openangioplasty and MCP stabilization. In 2A, 2 and 3A, CMC joint is stable. In 3B, 4 and 5, there is no CMC joint. So CMC joint is not only an important factor for classification, but also for the surgical treatment. The principles of polycization are skeletal shortening of the index metacarpal, rotation and stabilization of the index finger, and rebalancing of the musculotendinous units, wherein the transfer of the first dorsal and the volar intrinsic muscles for abductor and adductor function respectively is done. Scooge procedure is usually next is we are going to touch some of the cosmetic procedures and other important topics. Scooge procedure is what? Subcutaneous radiectomy, deep subcutaneous radiectomy with a smash, plication or resection, minimal access cranial suspension, and deep plane radiectomy. Scooge procedure, we'll be describing. It is a deep plane lift. Scooge procedure is a deep plane lift. Let us see one by one. These are the various facelift surgeries. In subcutaneous radiectomy, it relies only on stretching the skin tension. It is indicated in thin patients with skin excess only, without doses of the deeper structures. Complications are skin necrosis, widened scars, and facial distortion, especially anterior to the ear. Deep subcutaneous radiectomy, flaps are raised in the plane immediately superficial to the smash, leaving the smash down. It is a more robust flap, but a reduction in the risk of facial nerve damage is there. Subcutaneous radiodectomy with smash plication or resection. This is the standard facelift surgery. Okay, here the incision is begun at 1 centimeter posterior to the temporal hairline, continued in front of the ear, then carried upward and posterior to the back of the ear, and finally it is finished at the postauricular scalp. In subcutaneous radiodectomy with smash plication or resection, first of all, the skin flap is dissected lateral to medial. Then the smash is plicated or a narrow ellipse of smash is excised, wherein the direction of pull is superior and lateral across the midface parallel to the nasolabial fold. MACS, minimal access cranial suspension. Here, the smash is elevated in a vertical vector with a purse string suture and it is anchored to the deep temporal fascia. Deep plane radiectomy or the Scooge procedure is here cheek dissection is done deep to the smash layer. There is no dissection between the smash and the skin. So the skin and the smash act as a single robust composite flap composing of skin, subcutaneous fat, and the smash, which is tightened and secured. It is less prone to necrosis, but there is greater risk to facial nerve damage. Hamra's composite radiectomy is similar to a deep plane radiectomy, which also includes the orbicularis oculi muscle in the flap. Subperiosteal radiectomy, which was described in the Tessier, here it applies the craniofacial principles of facelifting. Initially, the craniofacial incisions are used. Recently, endoscopic technique is used. Whatever technique, the dissection is mainly subperiosteal, and therefore protection of the facial nerve is a great advantage and superficial to the plane of dissection because facial nerve is the last plane. Disadvantage is it limits the effects on the skin tension, and there is also laxity on the lower face and the neck. The complications of radiectomy are hematoma is the most common, flap loss or ischemia can be there, infection can be there, greater auricular injury, facial nerve injury can be there, pixie ear deformity wherein it is stuck on or pulled appearance is caused by the tension involving the facelift and the jawline. Marginal mandibular nerve can be there. Greater auricular nerve injury can be there because it crosses the midpoint of the sternocleidomastoid below the external auditory canal. And also, the most commonly injured symptomatic nerve during radiectomy is a greater auricular nerve. Auricular temporal nerves abnormal connection can cause a Fraze syndrome. Next is the topic on types of proliferative scars. A scar is a healed wound. Scar, there can be poor wound healing, which can result in chronic non-healing wounds, or there can be proliferative scars. Keloid is one form of a proliferative scar. For a keloid to occur, familial predisposition is required. There is an enlarged heaved up scar which extends beyond the margin of the original wound, which rarely regresses. It frequently results from minor trauma, and there is an elevated transforming growth factor beta. Hypertrophic scar is another type of a proliferative scar. Here, the scar is raised, erythematic, and pruritic. Here, though it is erythematic and pruritic, it remains at the confines of the original wound. Partial or the total resolution can spontaneously occur if the tension is relieved. It results due to trauma, incision, burns, or prolonged wound healing. There is an increased epidermal or a dermal thickness, lack of epithelial ridges, and the random orientation of the collagen fibrils here. Here also there is an elevated transforming growth factor beta. The mast cells are increased, and there is a decreased collagen production and collagen content in hypertrophic scars. Other type of a proliferative scar is called as a fibroproliferative disorder, wherein the capsular contracture, also called as the periprosthetic capsule, the palmar fascia contracture or the dupuytren's contracture, and even the rhinofiber due to tissue fibrosis are considered as fibroproliferative disorders. So the proliferative scars in plastic surgery can be classified as hypertrophic scars, keloid scars, and fibroproliferative disorders, out of which periprosthetic capsules, dupuytren's contracture, and rhinophyma are the three conditions. Scar management, the medical management is mainly silicone gel. Silicone gel can be used for keloid scars, hypertrophic scars, and even for surgical incision. The main mechanism is it is an occlusive gel. It hydrates the epithelium and therefore influences in the collagen remodeling phase of the wound healing. You have to wear the silicone gel as a ointment or as a gel sheet dressing for nearly 12 to 24 hours and 2 to 3 months at the onset of the visible scar deformity. Compression, pressure, and mechanomodulation. Compression garment can be used for burns and hypertrophic scars. It is prophylactically used in burns injury. All burns injury after healing or after grafting, we should use a compression garment. The influence on the collagen synthesis and remodeling. At least a pressure of 15 to 25 millimeters of mercury is the target pressure. Hence, a customized compression garment is the best choice. Pressure therapy is effective for keloid. It can be used as a post-operative adjunctive therapy for keloid. For keloid, sometimes in the year we use the intralesional keloid excision followed by intralesional steroid instillation followed by a pressure therapy. It is up to 80% effective, especially after completed surgical excision. Mechanomodulation is done to relieve the scar tension at the time of incision closure. A commercial device is used to mechanomodulate the scar. It is mainly used for truncal incisions and abdominoplasty. This is a recent advance given in the recent Graben Smith. Corticosteroid injections are the first line of therapy for keloids and hypertrophic scars. It is also used as an adjunct, just like I told for keloid scars, wherein you can use an intralesional keloid excision followed by injection. The dosage can range from 10 milligrams or 2.5 to 40 milligrams. Usually, lidocaine is mixed with it. And the solo steroid therapy is usually done once in every 4 to 6 weeks because the triamcinolone or the kinocort is a depot preparation. It stays for a longer time. So for the keloids, steroid pre-treatment, surgical excision, post-operative injection, and also a compression garment, cure rates are nearly 80%. Of course, with the recurrent steroid injections, the complications are skin atrophy, hypopigmentation, and pain with every injection. Radiation therapy, it is again an adjuvant therapy to the surgical excision of the keloid. Keloid excision is followed by radiation therapy within 24 to 48 hours. Radiotherapy is given as a single or as a multiple dose therapy. The cure rates are above 65% to 100%. Radiation mainly damages the keloid fibroblasts, collagen production, and the structure. Radiation monotherapy is usually not effective. Intralesional excision followed by radiotherapy is the best method. Generation of malignancy due to radiation therapy, especially in the pediatric age patient, is there. The area is prone to radiation-induced malignancy, and shielding of the vulnerable areas needs to be done from the radiation. Radiation therapy for hypertrophic scarring, very few data support it because hypertrophic scarring is amenable for surgical or medical line of treatment. The various side effects of radiotherapy are well known: hyperpigmentation, hypopigmentation, transient erythema, wound healing problem like low dose radiation, and soft tissue fibrosis are also there. Cryotherapy, in which a cryo needle is inserted, it is cooled down, and destruction of the keloid and the hypertrophic scars is done. But the recurrence rates are high as a as a monotherapy. It can be used at repetitive treatments. Molecular therapies, various agents used are 5-FU, bleomycin, mitomycin, tamoxifen, paclitaxel, methotrexate, interferon, etc. And the mechanism of anti-scarring in these molecular therapies is by interaction with transforming growth factor beta receptors and downregulation of the fibroblast function. Botulinum toxin nowadays are used for improvement of the surgical incisional scars. The final scar outcome is improved with an intraoperative injection of botulinum toxin 10 units per centimeter. Okay, using a split scar randomized trial, this was proven. The presumed mechanism of action is again inhibition of TGF beta 1 and cell cycle interaction. Therefore, there is a decrease in fibroblast cell function and fibroblast regulation. This is about the keloid scars. The next important topic is Kallen's triad is a future of what? Submucous cleft lip, submucous cleft palate, microform cleft lip, and Perry-Robin syndrome. Let us see. Microform cleft lip means there is a mild notching at the vermilion cutaneous junction. There is deficiency of the vermilion on that side. There is an indentation in the mucosa and elevated cupid's bow. In a microform cleft lip, there is also a nasal deformity wherein there is a lower alar nasal slumping, horizontal orientation of the nostril. Here you can see usually the nostril is obliquely oriented, whereas in a microform cleft lip, there is a horizontal orientation of the nostril. There is depression of the nostril sill. If you touch with the finger, there will be depression of the nostril sill and cephalorhetro displacement of the alar base. In a unilateral cleft lip, How to differentiate it from a microform cleft lip? In a unilateral cleft lip, the central and the lateral elements are separated uh, and they are greater than 3 mm in height compared with the cupid's bow on the uninvolved side. Only if it is like that, it defines a true incomplete cleft lip. Again, separation of the central and the lateral lip elements, the value should be greater than 3 mm in height compared with the cupid's bow on the uninvolvement side. Complete orbicularis muscle disruption is a hallmark of a true cleft lip, whereas in a microform cleft lip, the orbicularis oris muscle might not be disrupted. If the cleft extends to two-thirds of the heights of the height, orbicularis oris muscle fibers may be traverse superior aspect of an incomplete cleft. So Simonot's band, what is a Simonot's band? Simonot's band is a small skill band at the nasal sill of a cleft lip. It intrinsically lacks underlying ocular fibers. So sometimes you might get confused between a complete cleft lip and a incomplete cleft lip if there is a band. If inside the band muscle is present, then it's probably unilateral incomplete cleft lip. If there is no muscle fibers, then it is a complete cleft lip with a Simonot's band. And Simonot's, if it is a complete cleft with a Simonot's band, alveolar cleft is always present, which can be identified in the X-rays. Complete unilateral cleft lip features are there is a pathologic insertion of orbicularis oris muscle into the LR base on the cleft side. There is a pathological insertion of orbicularis oris muscle to the base of the columella on the non-cleft side. Usually, the muscle fibers decussate in the midline here near the philtrum. But if there is a gap, it either attaches to the LR base or the cleft side uh, muscle. Pars marginalis is present here. It is usually attenuated. And there is also loss of the white roll as it continues into the cleft margin. Nordhoff point is a critical landmark for the cleft lip repair. Okay, Nordhoff's point is it is the point where the cleft side vermilion height is at its greatest. And it is also coincides at the last point at which the white roll disappears or white roll is fully defined. It is usually present on the cleft side. Simple concept. Nordhoff point is present on the cleft side. It is a point at which the white roll is fully defined, at which the vermilion height is the greatest, after which the vermilion height also decreases and the white roll is also getting attenuated. Whereas on the non-cleft side, the vertical lip is usually diminished. There is a paucity of vermilion and the vermilion tracks into the cleft margin. Cleft nasal deformity associated with the unilateral cleft lip are lower lateral cartilage hypoplasia, LLC hypoplasia, clefting of the alar dome, lack of upper lateral and the lower lateral cartilage overlap, lower lateral cartilage subluxation, nostril horizontal orientation, ALR based displacement posteriorly and superiorly. Okay, ALR based displacement posteriorly and superiorly. The caudal septum is and the anterior spine is deviated towards the nasal non-cleft side and the nasal tip is deviated to the cleft side. Let me come again. The caudal septum and the anterior nasal spine is deviated towards the non-cleft side. The nasal tip is always deviated to the cleft side. The ALR base is displaced posteriorly and superiorly. Okay, lower lateral cartilage is subluxated and lack of the ULC and the lower lateral cartilage overlap. In a bilateral cleft lip, the hallmark is there are two labial alveolar palatine elements. So these are the labial alveolar palatine elements. It is also called as the lateral segments. There is a central protruding prolabial and the premaxilla element. Premaxilla means the upper four incisors, the anterior palate up to the anterior incisor foramen, and the prolabium, which is nothing but the filtral part of our normal lip without its muscle, and the columella also. This all part comprises the premaxilla. The premaxilla is usually protruded in the bilateral complete cleft lip, and the prolabium, there is no muscle at all. The posterior and medial collapse of the lateral segments. The lateral segments are completely collapsed posteriorly and medially. Locked out premaxilla means the premaxilla sits entirely outside the arch of collapse. As the both lateral alveolar segments collapse, the premaxilla totally locks off, and this is called as the locked out premaxilla. So, locked out premaxilla is a condition which is seen in bilateral cleft lip. Absence of a gingival sulcus in the premaxillary segment, and the prolabial segment is devoid of orbicularis muscle. These are all the pathognomic features of microform cleft lip, unilateral cleft lip, bilateral cleft lip. And in the central part, there is absence of filtral column, midline filtral depression, and central vermilion tubercle. Bilateral cleft nasal deformity are widening of the alar base, flattening of the alar domes, again subluxation of the LLCs over the upper lateral cartilage, underdeveloped anterior nasal spine, posterolateral displacement of the medial chloral plates. So cleft clip and palate affects the nasal. What I told initially is the unilateral cleft clip, bilateral cleft clip, whereas there is no palate deformity. In a combined clefts of the lip and palate, it affects the nasal floor, alveolus, secondary hard palate. There is a palate posterior to the anterior incisive foramen and the soft palate also. Open communication between the oral cavity and the nasal cavity will be there. It cannot generate a negative intraoral pressure for nursing. In cleft clip and palate, the soft palate clefts lead to the disruption of the palatine muscles, and therefore there is a lack of palatine elevation. There is also lack of velopharyngeal closure leading to the velopharyngeal incompetence. Because of the insertion abnormalities, there is a loss of inner ear drainage via the eustachian's tube, therefore causing a serous otitis media, which requires a myringotomy. The main palatine muscles are levator veli palatate. It is called as the primary palatine elevator. Tensor veli palatate is a secondary palatine elevator and modulator of the eustachian tube. These two muscles are not decussated in the midline, whereas it is abnormally attached in the posterior aspect of the cleft in a cleft palate. Due to the anomalous insertion in the posterior hard palate instead of the midline, there is a pathologic speech development, compensatory misarticulations, risk of mid-ear infections, and leading to hearing loss. Repeated mid-ear infection will lead to serous otitis media, like I previously told. Isolated cleft palate warrants usually a genetic evaluation because 50% of the isolated clefts have an associated syndrome or an anomaly, and the usually associated anomaly is a Perry-Robbins sequence. In Perry-Robbins sequence, the primary anomaly is a micronathia. There is a shortening retruded mandible due to mandibular hypoplasia. Because of a retruded mandible, there is a decreased oral cavity volume, which leads to glossoptosis or retroposition of the tongue. Because of the retroposition of the tongue, the two lateral palatine shells are unable to collapse and decussate in the midline and unite in the midline, and therefore there are cleft palates, isolated midline cleft palates. They are usually U-shaped cleft palates. So this is the Perry-Robbins sequence: micronathia, decrease in volume, glossoptosis, and wide U-shaped clefts. Other conditions like airway obstruction and feeding difficulties will naturally be present because of the falling of the tongue backwards. Treatment of Perry-Robbins sequence is mainly management of airway obstruction. Mild symptom means you can give supplemental oxygen and prone positioning. Severe symptoms means give temporary intubation, tongue lip adhesion, and mandibular distraction for in many severe cases. Submucous cleft palate. Submucous cleft palate is the one in which a Callinan striate is present. The classical Callinan striate is bifid uvula, notching of the posterior hard palate. If you touch the posterior hard palate, there will be notching, and there will be a midline mucosal attenuation or the zona pellucida. So my question's answer is submucous cleft palate as the Callinan striate. Here, what is anatomy? There is an anterior displacement of the levator palate muscle onto the hard palate, variable degrees of velopharyngeal dysfunction, lack of an overt cleft. There is no obvious mucosal clefting, but the muscle is clefted. Treatment is palatoplasty, even if the age of before the age of critical language development. So that is about the cleft palate, submucous cleft palate. So I have described the various anatomic features of the unilateral cleft clip, bilateral cleft clip, unilateral cleft nose deformity, bilateral cleft nose deformity, submucosal cleft clip, and submucous cleft palate. So some questions will definitely be there will be difficulty in understanding of these terminologies, and that's why I had put it as a point. False statement regarding the chronic wound healing strategies are PRP, there is no significant difference in the percentage of ulcers healed. PDGF, increase in the risk of rate of mortality secondary to malignancy. Dermagraft is a scaffold with the dermal neoblasts, and HBO is not indicated when revascularization in unsuccessful vascular ulcers, which is the false statement. The false statement is HBO is not indicated. All others are true statement. Let us see. The advanced strategies in chronic wound healing are employing biological therapeutics, enhance the matrix using dermal scaffolds like Matriderm, Integra, and exploit biophysical mechanical forces. Let us see one by one. Biological therapies are usage of cadaveric skin or xenografts, placental constructs, growth factors, hyperbaric oxygen therapy, biological skin equivalents, and stem cells. Various growth factors which are used are the human fibroblast growth factor, also known as its isoform is called as the recombinant human keratinocyte growth factor 2, recombinant human platelet derived growth factor, and recombinant human epidermal growth factor. Platelet derived growth factors or platelet rich plasma, topical PDGF is also called as the bicaplermin gel. Here, if lot of tubes are used, secondary malignancies can occur. This is what is the latest grabs 8th edition gives. PRP, most of them are using in clinical practice, but there is no significant difference in the percentage of the chronic ulcers healed with the PRP when compared to the plasma, placebo. Stem cells can be used for the treatment. Stem cells are nothing but the undifferentiated cells that possess the ability to mature into differentiated cells. Either one embryo germ cell can be used, or all the three. If one embryo germ cell is developing, it is called as a multipotent stem cell. If all the three embryonic germ cells develop, it is called as a pluripotent stem cell. Mesenchymal stem cells are a multipotent stem cell which is having an ability to migrate into areas of cutaneous injury. They secrete angiogenic and immune mediating factors and differentiate into skin cells. Now comes the HBO therapy. Hyperbaric oxygen therapy delivers high level of oxygen concentration at raised atmospheric pressures to promote the oxygen-dependent wound healing pathways. It is mainly indicated when revascularization is unsuccessful in vascular ulcers, and it expects the vascular ulcers to at least heal with oxygen therapy. One study of poor quality HBOT has found it is less effective at external shockwave lithotripsy. Cell cultured products are Appligraph. Appligraph means bovine collagen matrix with human neonatal fibroblasts and neonatal keratinocytes. Cells that produce the growth factors and ECM components are usually used here. Dermagraft is nothing but a polyglactin scaffold with a dermal neonatal fibroblast. Epicell is a cultured epithelial autograft using patient's own keratinocyte to treat large burns. It takes at least 2 to 3 weeks for these cells to grow, and the chances of mitosis and malignancies are also there, which cannot be ruled out. Scaffolds acts as a platform, and they are the in thing nowadays in plastic surgery reconstruction. They act as a platform for cell migration and angiogenesis. The scaffolds can be human origin, like donated tissue or cadaveric skin, or of non-human origin, porcine or synthetic, synthesized through extraction and cross-linking. Integra is a bilayer matrix of bovine collagen and glycosaminoglycan derived from shark skin that is lyophilized to form a highly porous scaffold. Allopatch is also a decellularized scaffold derived from human cadaveric tissue, and graphics is a cryopreserved placental membrane. Biophysical forces which can be used in chronic non-healing wounds are negative pressure therapy, extracorporeal shock wave therapy, and electromagnetic therapy. NPWT is nothing but a vacuum-assisted closure, which we are all famous with. Extracorporeal shock wave lithotripsy is used to break the stones. Here, the same acoustic waves are given as pulses to the tissues, and it has been found that there is an improved cutaneous wound healing by increasing the cell proliferation and stimulating angiogenesis. Electromagnetic therapies can be used in improved cutaneous wound healing, especially the pulsed electromagnetic field therapy is used. There is an interaction with the endogenous electric fields in the skin, and therefore there is an increased expression of the growth factors and nitric oxide, which also promotes the angiogenesis. So, biophysical forces like NPWT, extracorporeal shockwave lithotripsy, and electromagnetic therapies are also used. These are all recent advances which are not present in any of the previous Graben-Smith books. This brings me to the end of this short session on INISS NEET plastic surgery. We cannot cover the entire plastic surgery grabs in this 1 hour. I try to give more importance to the important topics which are usually chosen for questions in such central institute examinations, like wound healing, scar, cleft lip and palate, tendon injuries, congenital anomalies of the hand, cosmetic surgeries, especially facelift surgeries, and brachial plexus injuries. So, students, prepare well, sit on the sitters. I didn't revise on basics like skin grafts, flaps, etc., because they are all already given in the INISS NEET video, well explained with all the pictures. You have to go through with them again and again. My main intention to explain all this thing is few of the questions on the median now were asked in the previous INISS NEET, and the recent advances like usage of extracorporeal shockwave therapy, electromagnetic therapy, and PRP is not much useful. And the becaplermin gel can produce malignancy, our latest concept. And those who are attending this class might be scoring well if you listen to that. Similarly, when a question on brachial plexus is coming, listen or read the question and again. Usually the answers are very easy. See the time at which the patient is presenting. If the patient is presenting after 12 to 18 months, go for options which are tendon transfers. If the patient is presenting between 3 to 9 to 12 months, go for options like nerve transfers. If the patient is presenting within the first 3 months, go for a primary nerve exploration and repairs. In congenital anomalies, definite questions will be asked. Again, look out for the options, look out for the various pictures. And in tendon transfer, I presented median nerve injury because median nerve injury and ulnar nerve injury will also be asked in the clinical bay because there are very important nerve injuries, and tendon transfers are very important topics and high yielding topics also. Thank you. All the best.